So, good morning, everyone. I am Giacomo Grasselli. I've been introduced already, and I've been asked to tell you what is going on here. So, we are facing a a very important outbreak of COVID-19. Everything started on February 21st when the first patient was diagnosed in Codogno,
Bitte warten.
which is a small town around 50,000 people living there in south of Milan. And in 2 weeks, basically, I would say 18 days, the spread of the disease was exponential. So the disease spread first in the area around the Codogno, and from there in the area the Bergamo, which is northeast, and then it's now spreading to, I would say, all the region. Um, Now we have more than 5,000 uh, positive people who tested positive to the swab. Uh, Around 40% of positive subjects are needing admission or hospital admission for viral pneumonia and some form of respiratory failure, and 12% of positive people are in need for ICU admission now. It's a very high percentage, much higher than what was reported in studies published in China.
That is 12%, sorry to interrupt, 12% of the 40% that go to hospital.
No. It's 12% of the total. So now,
very important figure.
Yeah. So I don't know if we can compare our data with the Chinese data, because clearly the denominator depends very much on what's your policy about about the diffusion of the diagnostic to the population. So we stopped testing asymptomatic patients, asymptomatic contacts. We are now testing only symptomatic patients. So it could be that our denominator is not so comparable to the Chinese one, but this is our data. So for now, 12.7% of the patients who are positive at the swab come to the ICU, and they have some degree of respiratory failure, which is, I would say, quite severe. To give you some numbers, 88% of the patients in the ICU, who are now around 500, 88% are intubated and are receiving invasive mechanical ventilation with a median PEEP level of 14 centimeters of water, a median FiO2 of 60%, and a median PF ratio of about 150. And I would say that more than 30% of the patients are being prone. So we are not, let's say, underscoring the severity of the disease. All those patients are actually needing ICU and invasive mechanical ventilation. So it's a huge load on the system, because in Lombardy here, the total number of ICU beds before the crisis was around 800. And now more than 500 are occupied by COVID-19 positive patients. So we've been able to increase the total number of beds by about 30%. And we are currently trying to redesign our hospital system in order to optimize and to increase further the number of beds dedicated to those patients. But clearly, it's a huge huge load on the system.
Thank you so far. I can just inform people that are listening to this webinar that we also have some international listeners from Germany, from Greece, so that you know there are some people talking in between here that they are from other countries as well. So, Giacomo, we understand this is a huge catastrophe, a huge critical situation for your region. What about the collaboration between smaller and bigger hospitals, local hospitals and university hospitals? How does that work?
So I can tell you what we did. We have prepared a paper, which hopefully will be published soon, to describe how we organized it. And basically, what happened was that the day after the first patient, when we saw in 24 hours 35 positive patients, we, together with Professor Pesenti, who most of you will certainly know, he is my boss at the Polyclinic Hospital in Milan, we moved here to the government palace and we established a network of ICUs that we can call COVID units, something like that, between hub hospitals. So we selected hospitals because they have ECMO capacity, or because they have an infectious disease unit, and we asked all those hospitals to create some dedicated units where the patients can be isolated in cohorts. Clearly, we do not have enough single beds with negative pressure. So we decided to cohort the patients in dedicated ICUs who are, I would say, physically separate from the other ICUs in the hospital. They all have different pathways for dirty and clean, pathways. And so we every hospital, each one of these 15 hospitals, uh, created his own cohort COVID ICU. We started with 15 hospitals and 130 dedicated beds. And in 2 weeks, we ended up with 55 hospitals and more than 500 dedicated beds. And this is because most of the small hospitals around the red zones immediately became full of COVID-19 patients, and it was impossible to transfer them, all of them, to the hub hospitals. So even the small hospitals now are creating their own uh, dedicated, cohorted COVID ICU. And I have to say that this system is working quite well. We established a coordinating center here in the region, which is directed by myself, but most of the work is done by younger colleagues or retired colleagues who basically answer the phone. So everyone who has an intubated patients, COVID-19 positive patients, they call this unique number. So the doctor answers the phone and according to the history of the patient, his conditions, and in his geographic location, tries to allocate the patient in a dedicated COVID ICU, hopefully around the hospital which is calling. And so it's not only allocating the patients, it's also supporting the doctors who are calling if for the decision, for example, of admission to ICU, or supporting them if there is no space and they have to keep the patient in the operative room waiting for a bed. It's a huge workload. It's more than, I would say, more than 100 calls every 24 hours a day. So I was doing this work by myself during the first 10 days, and it was huge. And then I asked some people to help me. So now we have this service 24 hours a day, and all the patients are allocated to COVID-19 units after discussion with the coordinating center. So basically, this is how we established our network, and I have to say that it's working quite well. Lombardy is a very rich region. Uh, I believe that we have a very good health system, and I I expect that I don't know if we will be able to cope with the increasing number of patients, because as you can imagine, you can increase the number of beds, but you cannot increase the number of beds forever. And there are forecasts that say that in 2 weeks we should expect something like 2,000 ICU patients, which is clearly something that we cannot afford. But no public health system or private health system could afford such a huge load of admission in such a short period of time. So we are doing a massive effort from the clinical and organizational point of view. Everyone is working very hard, doctors, nurses, even administrators and politicians, I have to say. And the response was very quick. I think that the system in Lombardy is quite powerful. Okay, so it could have been very different in other regions of the country. But for now, we are how can I say? We are surviving, although it's hard. I mean, we increased by, as I told you, we increased by 30% the total number of ICU beds, basically with the same people. Okay, all the elective surgery was stopped. Only urgent surgery is now ongoing. Uh, the time-dependent diseases have been reorganized in hubs. So, for example, trauma and neurotrauma patients will be brought only to 3 hospitals in the regions, and so all the other neurosurgical units will be empty and reconverted in COVID units. So that we are trying to do to increase the number of ICU beds, because those units have doctors and equipment. Because now it's extremely difficult to buy a ventilator, for example, or to find CPAP equipment. So we are trying to reconvert cardiac surgery and neurosurgery ICU in COVID-19 units, simply by reorganizing the activity of the time-dependent diseases, which, by the way, have decreased a lot. I don't know why, don't ask me why, but the admissions to the emergency department for diseases different from COVID-19 have dramatically decreased. I don't know why, but this is what's happening. So now the ICUs who do not admit COVID-19 positive patients have a lot of empty beds. So we are, let's say, redesigning our system. As you can imagine, it's a huge effort, because we have like 100 hospitals, 100 ICUs. You have to move patients around. So it's been a huge effort, but I think that with this number of patients, it would have been impossible to create a single, very large COVID-19 hospital. It would have been impossible. We do not have 500, 600, 1,000 ICU beds in the same location. So this is what we did, and as you can imagine, we had to do it very quickly. I don't know if it's the best way. This is something that me and Professor Presenti decided to do, only the two of us, and we've been able to establish, I would say, a great network of people who is working very hard, but collaborating a lot, and I don't know, we are trying to deal with this, which could be a catastrophe.
I think we are all impressed in the way you have tried to solve the critical situation in such a short time amount, because it exploded in such a short time period. The treatment protocol that you try to, transduce to all the different hospitals, has it and the local treatment you give to these patients, has it changed over time, according to your experience with the patients?
Well, we have like a protocol for the triage of the patients in the emergency department. So according to the response to standard oxygen, they go to CPAP or non-invasive ventilation, basically CPAP, and when they fail, they go to intubation. We are recommending, obviously, for the first uh, phases of for the first days of the disease, control mechanical ventilation with protective settings, so 6 ml per kilo, less than 14 centimeter of water of driving pressure, and reasonable level of PEEP. Some centers select the PEEP according to the pathophysiology of the patients. Some others, which suggested who have less experience in the treatment of ARDS, we suggested to use PEEP FiO2 tables, prone positioning whenever possible. And I have to say that even small hospitals are now proning a lot of the patients. Most of our patients have good respiratory system compliance, and they are responders to recruitment and PEEP. Our experience, then I think that they are quite difficult to win when you try to stop neuromuscular blockers, when you try to go to lighter sedation and spontaneous assisted breathing. They have a very high drive and very high dead space, so very high ventilatory request. It takes a long time. This was observed already in China. I would say that we have patients ventilated for 20 days. And if you read the last paper published in the Lancet on mechanically ventilated patients, they had at 28 days 62% mortality, and some of the patients who were alive at 28 days were still on mechanical ventilation. So unfortunately, you have a very high number of patients and a very slow improvement of the disease. So most of these patients stay on controlled mechanical ventilation for more than 1 week. And they need high PEEP and for a long period of time. So this is for ventilation. The second, I can't tell you anything about steroids. Some people are believers and some people are not, but this is like the same old story. Personally, I would be very careful in using steroids in viral ARDS. But there are colleagues that I have a very high opinion of them, and they are convinced that we should use steroids, but we are not doing that now, and we are trying to have retrovirals, which probably are not very effective. We're trying to have other antivirals as for compassionate use, like everyone in the world. In China, they tried the plasma from patients who recovered. We are not doing that anymore. Clearly, we are submerged of requests of studies, but believe me, we are working like 20 hours per day, 7 days a week. It's very difficult to follow also the scientific aspect of this, which is extremely interesting. But it's very, very difficult to cope with the amount of work we have to do. For example, in our hospital, to give you an example, we had 22 ICU beds in total, 12 of a general ICU, plus 5 of a neurosurgical ICU and 5 of a pediatric ICU. And now we have 24 beds dedicated to COVID-19 positive patients, in addition, on top of the others. So we've almost doubled our beds with the same patients. Okay, we moved anesthesiologists and anesthesia nurses to the ICU because the operative rooms are empty now. But as you know, it's not the same. So we are trying to do our best with what we have, and until now, I have to say that we are, how can I say, we are facing this quite well, but it's a huge effort, for sure.
Can I ask a question from Hanover? And that is, how many of the intubated and ventilated patients will go into ECMO, or necessity of ECMO?
I'm preparing a paper for a journal. This is my personal opinion. I personally, I work with Professor Presenti. I've been working with Professor Gattinoni. So, I mean, you should not doubt that I believe in ECMO. Okay.
Yes.
In this situation, I'm wondering if it's ethical to use ECMO when you risk to have not enough ventilators for the patient. So
Yes.
the answer that we are, and I'm trying to write this. Unfortunately, I had to write this during the night time, and so it will not be a masterpiece for sure. But
the question then would be, I think, is how many patients die? We know the mean age of your patients that die is above 80 years.
Well, this was
how many younger patients are among those who die?
So I can tell you, the median age of the patients admitted to ICU is 65. 65 years old, but half are younger.
Okay.
We know from the literature data that mortality is steadily increasing after 65. We are working, as I told you, basically on the double number of beds with anesthesiologists, so not very experienced people in intensive care. In Italy, it's a little bit different than in the Netherlands. So we have a school of specialty, which is anesthesiology and critical care. So basically, we are all anesthesiologists. And then, at least in big hospitals, there are people who specialize in critical care. But in small hospitals, they do both. I would personally, I would reserve ECMO to very young people. I don't know. The example that I give every day is like a 30-year-old pregnant woman. Okay. Yesterday we intubated a 20-year-old boy, and clearly, if this boy will worsen, ECMO will be a consideration, but not for older people.
Yes.
Even with low comorbidities, because I think that that if you have a patient, let's say under controlled mechanical ventilation, protective ventilation for 5 to 6 days, and then he has to go to ECMO, you have to to foresee like 20, 30 days of ECMO, something like that, and so I don't know if you can make the equation that one ECMO is 2-3 tubes that you don't put. I don't know, but this is the feeling, like, because at least in the first days, you feel like that a tsunami is coming, and
Yes, I know, and we are just ahead of the tsunami, and so we are so grateful here in Hanover because we are awaiting the big storm to get this information. This is vital for us, for our planning inside the hospital, outside the hospital, with our conversation to politics and everybody. So one of the situations we are in is with the nurses, because they are very afraid of taking care of those patients. And the question is, were there any infections among the personnel, especially with the nurses on ICU?
Yeah, well, I can tell you. So in the first days of the epidemics, 10% of the positive swabs came from healthcare workers, okay? But this was because at the beginning, they were not aware of the disease, okay? The disease was diagnosed by chance. The first patient who was diagnosed had basically no epidemiological criteria. And only after 2 days of ICU admission, his wife recalled that he had dinner with some people coming from China like 20 days in advance. And so a doctor, against the advice of the infectious disease consultant, decided to test the patient for the novel coronavirus. And then the bomb exploded. And clearly during this period, all the healthcare workers had been exposed to that patients and then to other patients in the region without the personal protective equipment. So they got sick. I have to say that no one of them is in critical condition. Most of them were asymptomatic or only had fever. So the problem is that they cannot work. So that's the worst part of the story. After we recognized the disease and we started to cohort the patient and to treat them with the appropriate PPE, to my knowledge, and I'm how can I say, monitoring the situation of all the hospitals. To my knowledge, no anesthesiologist or anesthesia ICU nurse tested positive. So first advice is, if you wait for the storm, and of course I wish you that you will not leave the storm, you should do very simple things. The first is try to increase or improve your diagnostic capacity, because, for example, we had a lot of problems with the testing. At the beginning, a lot of asymptomatic contacts were tested, so a lot of tests accumulated. Then had not enough kits to perform the tests, and so we have out of 500 patients in the ICU, at least 40 of them are still waiting for the result of the swab. But once you see 10 of these patients, you clearly recognize the disease, which is the reason why in China, at a certain point, they stopped testing the patients. And also I have to tell you that we have a certain number of patients who test negative to the swab and are positive to the tracheal or bronchial aspirate. So don't trust the negative swab if the patient has an interstitial pneumonia, high fever during an epidemic.
Giacomo, a practical question for us. Those patients that are hospitalized, we talked a little about the timeline. When they are admitted to the hospital, how fast do they worsen? And are there differences among those that die and those that survive? I mean, do they look different?
This I can tell you because it's only 16 days. It looks like a year, but it's only 16 days that we are facing this, and most of the patients admitted during the first day are still there. So I cannot tell you, but what I know is that in the hospitals of the red zones, they had a dramatic situation in the emergency department for like 10 days with 50 to 60 patients on CPAP. Okay. And in some hospitals, the oxygen sources, the oxygen supply finished. So they had patients on CPAP with all the systems available for a long time. My feeling, I don't have the numbers now, is that out of 100 patients that you put on CPAP, 20 to 30% go well. Okay, so 20 to 30% stay on CPAP and then they are weaned. Around 25% of the patients fail but are not intubated because you make a decision of not escalation of invasiveness, and the remaining 50% fail CPAP or non-invasive ventilation. And for those patients, you should try to be quick in intubation. The problem is that if we had intubated quickly all the patients who very quickly failed CPAP, now we would have 800 patients in the ICU and not 500. So always you have to to make a decision comparing the resources you have and the number of patients you have to cope with. So that's why, for example, in the first days, the median age of admission of the patients was higher, probably because older people were failing CPAP more quickly. And now, in the last week, the age of the patients is decreasing. Maybe because we tried to, younger people seem to tolerate much better hypoxemia, and maybe we are forced to keep them on CPAP for a longer period of time. And then when they fail, they fail. What an observation that I shared with Chinese colleagues is that those patients seem to tolerate very well hypoxemia. So you can see patients with 70, 80% of oxygen saturation who are eupnoic, and apparently you would not say that they are so hypoxemic. They respond well to CPAP, and all of a sudden, uh, they crash. So it's um, it's very challenging because it's severe hypoxemic respiratory failure. You know that when you try non-invasive ventilation or CPAP, you have a higher risk of failure, and again you have to cope with the limited number of ventilators, ICU beds, and so on. So we are still trying to offer CPAP to every patient and to intubate as early as possible younger people. It's difficult, and you learn day by day. But if I had to give you an advice, that you should try to report to your government, which I think is the most important message, is that you should try to educate the population before this comes, because the only way to survive this is to avoid having people around in the malls, in the cinemas, in the restaurants. People, especially older people or people with comorbidities or immunocompromised, should stay at home. They should wash their hands as much as possible. They should avoid touching ear, nose, eyes, and so on. And they should avoid crowded place. And for us, it's very difficult to convince the government to put in place very strict containment measures. But these are the only way to avoid a catastrophic spread of this. Because if this spreads, like in Italy, you could easily make a calculation. Let's assume that it behaves like pandemic flu, okay? During H1N1, 15% of the Italian population was infected, and this comes from serological studies. Okay, so it's clear data. Okay, so 15% of 60 million is, you can make the calculation. Even if 5% of these, not 12%, but even if 5% of these, sorry. So let's say 10%, which is easier to make calculations. So 60 million people, 10% makes 6 million people positive. Okay, of these, 90% have no symptoms. 10% are symptomatic. It means 600,000 people. Of these, according to our data, 10% go to the ICU. It's 60,000 people admitted to ICU in like a few months. In Italy, we have a total of 5,000 ICU beds. Of these, 50% die. So you have to expect thousands of deaths if you do not stop the spread of the disease. So clearly the only way is to reduce the spread of the disease. It's extremely contagious.
I mean, I think these were really important take-home messages from you. And just a final question, are you still seeing increasing numbers? Have you reached the top, or can you breathe? It seems you are still increasing.
We are still seeing increasing numbers in the positive tests. the numbers are now steady or even slightly decreasing in the red zones, which clearly demonstrates that containment measures work. You have to think that, to give you an idea of the phenomenon, the red zones, most of the patients that we have now in the ICU come from the red zones, okay? They come from some geographical areas that account for 100,000 people, okay? Something like that. And we have 500 patients in the ICU. If this comes to Milan, it's 2 million people. Again, you can make the calculation. It's something that you can certainly not, you can only be overwhelmed. That's why it's very important to avoid the spread within the region and within the country. So I'm convinced that government should be very strict. I don't know if you have to do like in China, that you have the army on the streets, but very strict. And even here in Italy, where they are, they have the bomb exploded, there are still, some of them are still reluctant. But if they will follow this way, it will be a disaster. I'm sure. I'm sure that it will be a disaster. We can only tell this, but then we don't make the decision, the political decision, as you know.
Giacomo, I think this was very informative. This was very emotional. This is tough. We see that you are working a lot, that this is exhausting, but there is still some energy there, and I hope that you can continue to do good work and also to teach us something. I'm very thankful that you took your time to doing this for us.
Thank you for the invitation.
And say hi to all friends in Italy and keep up the good work.
Okay.
Thank you.
Thanks from Hanover to everybody. Thank you very much.
Thank you. Thank you. Bye-bye.